Hello everybody, my name is Bella and I'm a nursing student, and today we're going to be talking about potassium. We're going to do a pretty good deep dive over what is potassium, what is its role in our body, why do we care about it, and the difference between hypo and hyperkalemia. So let's get started. I gotta take my focus shot first. Lion's mane and matcha. So what is potassium? It is a charged molecule. It's charged, and it is found mostly inside of your cell, about 98% of it. Keep that in your brain. Most of it is found inside of the cell. Only about 2% is found in your bloodstream, which whenever we do lab work, that's what we're measuring, is how much potassium is in the bloodstream. Not inside the cell, inside the bloodstream. So there's not supposed to be very much in your bloodstream at all. Even a slight increase in your potassium in the bloodstream could mean something significant, because your body works really hard to keep that extracellular potassium tightly regulated. So our normal potassium range is 3.5 to 5, and even if it's off by a little bit, that can mean something significant. If it's 5.5, that's concerning. Even if it's 3.0 instead of 3.5, that's concerning. And how I remember the normal range is potassium is found in bananas. And in a bundle of bananas, you get between 3 and 5 bananas, and you want them half ripe. So 3.5 to 5. One thing I want to express is, as nurses, whenever we are giving a patient potassium, replenishing their potassium, we're not just giving them potassium into the blood. We want it to go inside of the cell, and that takes time. That is why potassium is given slowly. It's very important that it finds its way back into our muscle cells and cardiac cells, so that's why we give it slowly, as well as it can burn really, really bad. Now, I know I've said this 100 times, but it's because it's that important. Potassium is supposed to live inside of the cell. But there are certain disease processes that cause the potassium to shift, such as shifting outside of the cell. So whenever you do your blood work to measure how much potassium is in the bloodstream, you may think, oh, our potassium is elevated, but really it's just shifted from the intracellular to the extracellular, where it doesn't belong. And that can still cause a lot of issues. Or the exact opposite that can happen. Even that 2% that is supposed to be in the extracellular space, it could find its way in the intracellular space, and now you have no potassium in the bloodstream, and that's not good either. So even though the total amount of potassium in the body stays the same, where it's all located makes a big difference. Now remember, in the beginning I said that potassium is a charged molecule. That is important. Why is it important? Because our cells use electricity to function. Anytime your heart wants to beat, those cells need electricity. If your muscles want to move or your brain is trying to send a signal, it relies on an electrical signal, electrical functioning. All of our cells are sitting there waiting to fire the moment it gets a signal. Think of it like this. When our cells want to do something, for example, a muscle contraction, even this, that action is called depolarization. When the cell fires and gets the signal and does what you want it to do, that is depolarization. After that action has happened, the cells need to reset. That is called repolarization. So repolarization, reset. Think of it as, once you use a battery, it needs to charge in order for you to use it again. That's what our cells need. Even though it's happening really, really, really fast, our cells are still doing that. The action that it's giving off is depolarization. The resetting is repolarization. I'm not going to go too in depth over the resting membrane potential because that's more A and P stuff, but it is important with potassium's role in how our cells function. Now, I want you to zoom out and look at the bigger picture, because we kind of talked about the cells individually, but zoom out and look at our heart and imagine it is made up of millions of those little tiny cells. Okay, and every single one of those little cells has to have the perfect and right amount of balance between sodium and potassium coming in and out of that cell in order for it to work properly. What's happening to these cells whenever it decides to activate? Sodium is going to rush into the cell. There's the threshold that needs to be met before the nerve can say, okay, I'm going to activate, I'm going to fire. Once that threshold is met, then depolarization happens. Remember, the firing is depolarization. After the depolarization has happened, after the action has happened, it needs to reset. When it's resetting, that means that potassium is flowing out of the cell. That is repolarization, the action of potassium leaving the cell. If you have too much potassium outside of the cell or inside of the cell, when the cells try to do these action potentials and try and fire and reset, remember, they're charged. So if there's too much outside or inside, that's going to throw off the movement of those potassium molecules going in and out of the cell. So that's gonna affect when the cells fire and when the cells reset. So again, every time your heart is beating, those cells are charging, meeting the threshold, firing, and then resetting. And it happens really, really fast, but that's what's happening. They are charging, firing, resetting. And the activation is depolarization. The resting is repolarization. It's literally like a revolving door. Sodium comes in, boom, the heart contracts, potassium leaves, and the heart is resetting. And this repeats over and over and over again with every beat, every muscle movement, and every nerve firing. Examples of firing is, again, I said the heart beating, the muscles moving, your GI tract. Whenever you're pushing food through your intestines, it has to have the right amount of charge to fire and keep doing that, as well as our thoughts. Me thinking and talking right now, that is requiring the action of potassium and sodium going inside and out of the cell. So when potassium gets too high or too low, that revolving door can either get stuck or start spinning the wrong way. And that's whenever you're going to start seeing some weird signs and symptoms in their muscles and their heart. So when you think of potassium, always associate it with these two major body systems. One is the heart. It's going to affect the heart's rhythm and contractibility, as well as your muscular system, your skeletal muscle and your smooth muscle. It's going to affect how our muscles contract, and it can even lead to weakness. Okay, let's jump into hyperkalemia. This is whenever there's too much potassium in your bloodstream. So it's too much potassium outside of the cell. Some cardiac issues that you're going to see is peaked T waves. That's a big one for NCLEX especially. You also could see widened QRS, bradycardia. If this is not addressed soon enough, it could turn into asystole or VFib. So if your patient is experiencing any sort of elevation of potassium, we want to keep them on a cardiac monitor, because having cardiac dysrhythmias is a big issue that happens with patients in hyperkalemia. So what's going on in our heart cell muscles? Now, remember, whenever the heart is resetting, potassium is leaving the cell. And it's all based off of different electrical charges. Well, now there's so much potassium outside of the cell. Whenever the heart cells are resetting, potassium's leaving and it's saying, oh, there's already plenty of us out here. Let's go ahead and reset. But the cells haven't had enough time to actually recharge enough to have enough energy to depolarize again. So it's almost like you're trying to go full throttle, but it hasn't fully charged up yet. So you're not going to get the same amount of power and energy that you would initially if it truly repolarized. This can lead to early or extra beats because we're depolarizing at either too early or at different times. And this is going to keep happening. That's when you're going to see the peak T waves. Eventually, though, there's going to be so much potassium outside of the cell that potassium is not going to want to leave the cell to repolarize. And that's what can lead to bradycardia and eventually asystole. So they always say that in hyperkalemia, your cells become overly excited. And that's because, like I said, potassium has to leave the cell in order for it to reset. Well, there's too much potassium outside the cell, so potassium's not wanting to leave. Now that repolarization is happening really quick. So in the beginning, it's going to be like, okay, fired, let's start resetting. Oh, heck, there's too much potassium out here. Let's depolarize again. So it's very overly excited and it's going to be activating really, really quick. But eventually, it's going to stop activating altogether. Okay, so to wrap up the cardiac, the potassium's job is to reset the heart after each beat. When potassium is too high, it is resetting too quick or unpredictably. And eventually, it's not going to be able to reset anymore, which means it's no longer going to be firing, because in order for it to fire, it has to reset. Now, this is also happening in our skeletal muscle. In early signs of hyperkalemia, you may see some twitching or cramping, and that's because whenever these cells are sending off the signal to contract, so the depolarization action is to contract, there's too much potassium outside of the cell, so now potassium doesn't want to leave in order to repolarize, so it's now depolarizing again too quickly, and so that's going to result in twitching. But remember, eventually there's going to be too much potassium outside of the cell that potassium is no longer going to want to leave, and potassium has to leave in order for it to reset. And in order for the cell to fire again, it has to reset. So that eventually is going to lead to muscle weakness and even paralysis in extreme cases. You want to think of it as like you're trying to sprint, but you're never taking a break. So you sprint, but normally you would take a break in order to sprint effectively again, but you never take a break. So the muscles never fully recover between contractions. Eventually, it's just going to give out. The patient may also experience paresthesia, which is like numbness and tingling in their extremities or in their face. That's because potassium is also responsible for sending nerve signals. So whenever potassium is all out of whack, those nerve signals also get all out of whack. Speaking of nerve cells, you can also see confusion or brain fog because you also have nerve cells in your brain. So if the potassium is off them, you can also see some neurological symptoms as well. A very, very late sign of hyperkalemia is going to be difficulty breathing because think, what is your diaphragm made out of? Muscle. And this affects muscles. So you're going to have that same effect on your diaphragm, and eventually it can paralyze your breathing muscles. So yeah. What is causing hyperkalemia? Some causes can be consuming too much potassium, which normally it's not that big of a deal, but if you have kidney disease, then you can accumulate too much potassium in your bloodstream because your kidneys are responsible for excreting potassium. So if you're eating a lot of bananas, or if you are taking like those salt supplements that have a bunch of potassium in it, if you have issues with your kidneys, it may not be able to properly excrete, which is going to raise your potassium levels. Another thing is going to be cellular death or injury, because remember, potassium lives mainly inside of the cell. So if something happens and those cells become damaged, it is going to pour all of its contents into the bloodstream. So if you have like a crush injury or rhabdomyolysis, that can cause potassium to be leaked into the bloodstream, and now you have hyperkalemia. Another thing that can cause hyperkalemia is acidosis. So if you don't know how acidosis works, here's just a brief little overview. Our cells don't like its environment to be too acidic. So what it's going to do is compensate. And the cells are going to say, hey, I will take a hydrogen, which H plus hydrogen is what causes the acidity. It says, I'll take a hydrogen, put it inside of my cell, and swap you out with a potassium. So that's what the cells are doing. They're taking the hydrogen outside of its environment, putting it into the cell, but kicking potassium out. So now potassium is leaving the cell where it's supposed to be, and it's going into the bloodstream. So now you're going to start accumulating potassium in the bloodstream. This can happen with metabolic acidosis, lactic acidosis, or even like diabetic ketoacidosis, anything that's going to cause the cell's environment to become very acidic. Another cause could be insulin deficiency. Why is that? So insulin is the guy with the key that unlocks the door of the cell, opens it up, and allows glucose to come in and be used for energy. Well, another thing that it lets in is potassium. So if you don't have enough insulin, one, it's not going to let enough glucose in, but it's also not going to let enough potassium inside the cell. So potassium is supposed to be inside the cell. Now it's accumulating out in the bloodstream. That's going to result in hyperkalemia. And then we kind of discussed about it a little bit ago is kidney dysfunction. Kidneys are what excrete potassium. So if they're not functioning properly, then it can accumulate in the bloodstream. Another thing is certain medications. So ACE inhibitors and ARBs, you need to know the mechanism of action for these drugs, because this is why the patient's getting hyperkalemia, is because it's affecting the RAS system. And the RAS system normally is activated when there's a drop in blood pressure, something like that, and it wants to hold on to fluid. So what it does is it holds on to sodium and water and excretes potassium. Well, whenever you're taking these medications, it's blocking that system. So now it's going to do the opposite. It's going to excrete sodium and water, but hold on to potassium. So that can result in an accumulation of potassium. One little thing too is NSAIDs, and that's just because it can reduce blood flow to the kidneys, which can harm the kidneys, and that's going to result in the kidneys not being able to excrete potassium and it accumulating in the bloodstream. How do we fix this? Well, a big thing we want to do is prevent anything life-threatening from happening, which is the heart giving out on us or going into deadly dysrhythmias or even asystole. So keep your patient on a cardiac monitor, and and we're going to give them calcium gluconate. It's really going to stabilize the cell membranes as well as make those cells less likely to fire so erratically. So it's going to reduce all of the excitability. Next, we're going to want to shift potassium back into the cell. We don't want it all out here in the bloodstream. Put it back in the cell. And what was one of the things I said could cause hyperkalemia? Insulin deficiency. So let's give them some insulin, right? Because insulin is going to unlock the door to the cell and let potassium come inside. But we got to be careful because why? We don't want them to start experiencing hypoglycemia. So normally when this is given, they do insulin and D50, and D50 is basically glucose. So it's going to prevent that patient from having hypoglycemia. So with insulin, we're not removing potassium, we're just relocating it in order for us to buy some time, because that is going to work faster than excreting it from the body. A couple things we can use to excrete it from the body is loop diuretics, for example, furosemide. You would use furosemide over any thiazide because furosemide is a lot faster acting and it's a lot more intense, but it's going to force the kidneys to excrete potassium in the urine. Another thing that we can use is kayexalate. And kayexalate binds to potassium in the GI tract and it's going to come out through your stool. If the patient has kidney disease and is unable to excrete the potassium, in severe cases, we may do dialysis, so then the potassium will be removed directly from the bloodstream. Okay, let's move over into hypokalemia. So that means either all of the potassium that was outside the cell has now gone into the cell, or you have lost potassium levels altogether. And this can happen through the kidneys or through GI, so nausea, vomiting, or peeing. So the causes of hypokalemia, like we just said, GI losses, so vomiting, diarrhea, or even if they have an NG tube, NG suction, because the stomach and intestines have a lot of potassium and that's where it's all getting absorbed. So if you're throwing it up or if you're having diarrhea, you're excreting it before it has time to be absorbed. Next is diuretics. Some of these diuretics, we actually call them potassium wasting diuretics because the diuretics are going to remove sodium and water, but potassium is going to just hop right on with it. The only one that is a potassium sparing diuretic is spironolactone. If you have a condition where you have an increase in your aldosterone, for example, Cushing's syndrome, like hyperaldosteronism, remember the RAS system. So aldosterone is going to be released and that's going to tell the kidneys to hold on to sodium and water and excrete potassium. So if there's too much aldosterone, it's going to excrete too much potassium. And we talked about the treatment for hyperkalemia is insulin, because insulin is what brings potassium back into the cell. So if you give too much insulin, then this can lead to too much potassium going into the cell, causing the patient to become hypokalemic. Your patient may also start experiencing constipation because it's affecting those muscles as well in our intestines. And there's not enough potassium for the cells to reset. And you need those muscles to be activated in order to push that food through. So the peristalsis is going to slow down. If you check their deep tendon reflexes, you're probably going to see a decrease in them, which is hyporeflexia. And that's just because there's a decrease in nerve conduction. They are not able to reset, so they're not able to set off an action potential. And lastly, of course, in late stages, you could see shallow breathing, and that's because the diaphragm is a muscle too, and it's not able to reset. So that means it's not able to activate those cells again to keep on breathing. So what do we do about the treatment? We want to fix the underlying cause. So if they are vomiting, get them to stop vomiting. If it's from diarrhea, get them to stop having diarrhea. Alkalosis can also cause this, so fix the pH if you need to. And then it's preferred to do oral tablets. It works slower, but it does replenish the intracellular safer, because remember, we want to give this slower because we need time for the potassium to properly shift between the intracellular and the extracellular. Another option is giving this with IV, and you're always going to dilute this with saline, but we want to give it slowly, and we never, ever, ever do IV push. If you do IV push, your patient is dead. So don't ever forget that, because that is an unforgivable mistake. That patient will go into cardiac arrest because of that spike in potassium, because it takes time for it to go from the extracellular to the intracellular. So this is going to be given slowly and diluted. So yeah, that's potassium. It's not just a number, it's a reflection of what's happening inside of your cells. And when those levels shift, it's going to change how your heart beats, how your muscles move, and how your body functions. So until next time, guys.